On any one day in New Devon, we have 500 people in a hospital bed who don't need to be there. And that's not good for patients, that's not good use of resource. And when you speak to the public, everybody can describe what they want, but at the moment we're not able to deliver an organised care in that way.
When you take people who have dementia that have illnesses out of the community, living in their own homes, managing very well, you put them into a hospital setting, you know, it's very disorientating for them. They become very confused. You know, you're making them reliant on individuals and care staff that they don't necessarily know or have relationships to.
We know that their muscle wasting develops very quickly, and we know that people become depressed and actually quite despondent because they're not able to return back to their familiar environment of home. The new model of care is an evolving model of care we're already delivering. It's really of three phases, so it's a proactive approach to identifying people who are likely to be admitted to a hospital. The second phase is actually having a much more responsive place where clinicians and healthcare professionals can go to get help at the point of identifying that patient is in crisis and needs hospital admission, and that will hopefully be a response within 2 hours. And the third part is building on that, having a much more robust and comprehensive service that we can use to bring people back into their homes in a more timely way, and that's more domiciliary care, therapy care and district nursing care to support the medical input that allows those people to be cared for safely at home. The process that's being proposed by the Clinical Commissioning Group is a further development of a model of care that is already established quite well in some areas.
That suited us best was having somebody in the mornings, and we agreed a time, so the person who came would come at 9 o'clock or 9:30.
Not too early.
Not too early. Upstairs to our room, and would help my wife to get out of bed, and help her into the bathroom, to go to the loo, help her to have a wash, help her to get her clothes on, and then help her to come downstairs. And then they did their reports and went home. And the same thing happened in the evening. They'd come in the evening and help her to go up the stairs, help her to get undressed, go to the loo, have a wash, clean her teeth, get into bed, tuck her up, give her a hot water bottle, do their notes, and off they went home. And that was really excellent. Yes. They even offered to make the bed, but I wouldn't let them do that.
It made me feel, I think, I mean, they were very nice. I had nothing whatsoever against the person who came, but I didn't really want that much help.
Well, she thinks she didn't want the help, but Nurse Bernard here would have had to work 3 times as hard. And I was concerned about damaging my back, heaving her up from the bed and heaving her up from the chair. And anyway, in any case, I'm not a skilled carer. And it was extremely comforting to know that there's some people coming in who did know what they were doing. And I think it helps the healing process to be confident that you're being looked after by people who know what they're doing.
What we've found with Hospital at Home is that patients feel much more in control of their care and what happens when and to what extent, and therefore remain very involved in any decisions that are made about them. It's always with them.
Patients who go into hospitals become reliant on healthcare, and healthcare over the years has become, to me, disabling.
It's a big cultural change for everybody. It's thinking about the patient as an individual. It's personalising the plans around that individual and working in a much more integrated way with other healthcare professionals.
Looking after patients in their own homes, providing the services in their own homes will only enable these people to live well, live longer in the community setting.